welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breidster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluations at the close of today's program. Continuing education credits are available after you complete our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. As for today's program, we will be taking your questions throughout the hour by phone. You can call us at any time on our toll-free number, which is 1-800-452-0662, or you can send written questions to our email address, phlive.ny@gmail.com. And you don't have to wait till the end of the hour. We encourage you to send questions at any time that they come up. Today's program is Teens and Taboo, a look at prevalence and prevention of sexually transmitted infection. Our guests are Audrey McDuff, a sexuality educator and TeenView co-advisor at the Mohawk Hudson Planned Parenthood, and Rob Curry, a sexual health care consultant and trainer. Thank you both very much for being here. We're really excited to have this very important conversation together today.
This is great.
So Rob, we're going to start the conversation with you today and start off by talking about when we think of teens and STIs, what is the picture that comes to mind and who's really at risk? What does that look like?
Well, I always like to start off showing a picture of two young people. And it reminds us to think about what does a young person look like who has an STI? Do they look like these two people in the picture? And it reminds me to always put in check that a young person who has an STI could be anybody. And that's why it's important to pay attention to this issue.
Absolutely. And so since we know that it can be anybody, there's not a specific group that it looks like, when we look at the big picture, there are some pretty startling statistics out there. Is that correct?
There are. According to the CDC, we have about 20 million new infections in the United States a year. That would give us a total of 110 million STIs totaling existing altogether. And right now, our numbers are pretty even. The annual number of new infections between girls and males, girls about 51%, males about 49%. And we're seeing the trends of a lot of the common STDs or STIs, especially HPV. Young people are especially susceptible to sexually transmitted infections. What we found is that young people aged 15 to 24 account for over half of all the new STIs, even though they make up 25% of the population. And we should pay some attention to the highest infection rates. Females, for example, have the highest rates age 15 to 19, and males have the highest rates between 20 to 24. And I think it's important to note the age difference.
Sure.
We would say that about 46% of American high school students right now, according to the CDC, have had sexual intercourse and are at risk of STIs. The challenge with this statistic is that it does not include those students who are participating in other types of sexual behavior, including oral sex and anal sex. Right now, about 1 in 4 teens contracts an STI every year, and 9 million new cases of STIs among 19 to 24-year-old youth are occurring. What's more interesting is, why is this happening? You know, we know that 6 in 10 sexually active high school teens report using condoms at last intercourse. However, that leaves 4 out of 10, 2 out of 5, who are not using a condom or some type of barrier method at last intercourse. Almost 18,000 new HIV infections are happening among 13 to 29-year-old youth, and less than half of adults, which include 18-year-olds, are being tested for STDs, including HIV and AIDS.
So I think in general we all acknowledge, right, that there's a problem with STIs, but the information you shared when you paint the pictures like that, I mean, that's really pretty shocking information. So what are some of the main points that we need to think about as we start this discussion?
Well, I think we have to think out of the box. I think we have to think in a new way. We have to have a paradigm shift. You know, right now the United States has the highest rates of teen STIs and HIV of all developed countries. And LGBT teens, lesbian, gay, bisexual, transgender teens, are especially at high risk of STIs and HIV due to many factors, medical and psychosocial.
So if you're saying the U.S. has higher rates than any other developed countries, can we spend a few minutes talking about what's going on in those other countries and what does the data look like from those places?
Sure. If we take a look at male condom use, for example, by country, again, the United States fails on the report card. And compared to France and Netherlands and Germany, condom use by males is at the lowest of 75%. And what that means is, compared to the higher rates, such as in France, where there's 88% of males using condoms, we're not using them very often, we're not using them consistently, we're not using them correctly. To counter that, we also have to pay attention to other types of barriers. And I think the female condom is finally beginning to get its attention in America. And I know that in New York State, we've had the female condom demonstration project. I'm not sure if it's caught on. When we look at, again, France, Netherlands, and Germany, we see higher use of female condoms by young women. But in the United States, we see a less percentage use of the female condom. I think the big question here is, what are young women thinking that they need protection from? And I think it often goes back to the adage that they need protection from pregnancy prevention, and often they forget that sexually transmitted infections are equally important. Remember, the female condom was invented so that if the male didn't use a condom, the female could protect herself from getting pregnant as well as from contracting a sexually transmitted infection.
Sure. And you have data as far as the female contraceptive use beyond the female condom as well, correct?
Yes, which of course, you know, there's a little conundrum going on here. You know, and the conundrum is, you know, we see teen pregnancy rates dropping, but we see STI rates skyrocketing. And again, you know, compared to the developed countries, France, Netherlands, and Germany, the United States has, I would say, a fairly abysmal record of female contraceptive use. So if we're thinking that women are trying to only protect themselves from getting pregnant, again, only about 11% of females are using some type of hormonal birth control. So I think we're probably in a quandary here, trying to prevent both unintended pregnancies and STIs.
Yeah, and I think you're right in that a lot of times on the forefront of teenage women's mind, they're thinking more pregnancy because that's the more immediate consequence, but really needing to shift the focus and think about there are other consequences of pregnancy, or of sexual activity as well.
I think when we do sex education, we often talk to young people and we try to ask them, what are you trying to protect yourself from?
Yeah.
You know, and or whose responsibility is it? And we forget that both the males and females are responsible for ensuring that a pregnancy doesn't happen and an STI doesn't get transmitted, and both males and females are at risk for sexually transmitted infections.
And especially it's important to look at the type of relationship. I mean, pregnancy prevention might not be relevant for all relationships.
Sure.
So you have to meet them where they're at.
Absolutely, that's a
Exactly
very
right.
good point. Now, you also have some data from the youth risk behavior surveillance and talking about some of the things that teens are doing and some of the consequences of teen activity. So can you share some of that with us?
Sure. For those of you who aren't familiar, the Youth Risk Behavior Survey is a national survey that's done by the CDC, and they ask high schools to administer it. Many high schools do. And they take all that data and they compile it, and they try to show how states compare to the overall total of the United States as a whole.
Sure.
So for example, in New York State, when we look at the question, how many young people have ever had sexual intercourse, we see that 42% have, compared to the United States, where 47% have overall. What's startling is some other statistics, though. We're very, very close. Sexual intercourse for the first time before age 13, 5.7% in New York State, 6.2% nationally. Or had sexual intercourse with 4 or more persons so far during their life, 13% in New York State, 15% in the country. And what this is telling us is that sexual intercourse is happening, whether we want to acknowledge it or not. It's happening at younger ages, and if we're going to look at risk factors, multiple partners is indeed an incredible risk factor.
And this is just data that youth report, right? So there could be even greater numbers of youth that are not comfortable reporting on a school survey.
You're exactly right. Or the schools do not want the survey to be given because it's too controversial for a variety of reasons. But it gives us a good indicator of what's going on out there. You know, our numbers are not that far away of what's going on nationally with what young people are doing. And so I think it's important to take a look at that. And if you're interested, the Youth Risk Behavior Survey is done every couple years. I think the most recent one is probably 2011. It was combined with some public policy program information on June 3rd. If you Google it, you could go to the cdc.gov and you can find all this information. You can pull out some of the different metrics by state and how you compare. And it's really kind of a neat website if you enjoy doing that. But it does help us paint the picture to realize that statistics aren't just something on paper. They're something that are very, very real. And sometimes they're very disturbing because they have an incredible impact on how our young people think about their vulnerability and their risk for STIs.
Sure. Now, the numbers you were just sharing with us are sort of an overall picture of teen activity, but what about disparities between what we're seeing with different racial or ethnic groups and their risk or their incidence of disease?
Right. We know right now that there's a rather disturbing inequity or disparity occurring between white, Mexican American, and non-Hispanic Black African American women aged 14 to 19. And as you see by the chart, non-Hispanic Black women, 48% of them aged 14 to 19 have an STI or had an STI, compared to 19.7% of their Mexican American cohorts and 20% of non-Hispanic or white. And I think that this again reminds us that not only do certain populations need attention, but we've overlooked certain populations in getting our messages out. So we have to make sure that our messages are culturally competent, and we have to pay attention to historical underpinnings, cultural norms, and all the things that are necessary to be able to reach that population to get them the information that they need, as well as access to testing.
Absolutely. Now, I know Audrey is going to be speaking more later about specific things that you do in New York State and the educational component. But Rob, even in your work, you've got some data on New York State. So talk to us about some of the things you've seen and how that relates to what you've been sharing so far.
Well, unfortunately, it's not good news. Just as the United States is filling in the report card of teen pregnancies and STIs, New York State continues to rank first with the numbers of STDs and STIs in the United States. And that's incredibly disturbing. I think what's equally disturbing, though, is we often think that, it must be New York City or it must be that county. And I think we have to realize that every county in New York State has a teen STI or STD problem, because all of our teens populate our counties. All of our teens are receiving information or poor information from the places that they gather their information, either from their peers or perhaps from the internet, and that the myths of STI still continue to abound. And most young people think that it can't happen to them. And again, the only thing they're trying to concentrate on is not getting pregnant.
Sure.
And I would know if someone had an STI, they would tell me, or if I don't have any signs or symptoms, I must not have one, it went away. And we know, of course, that the bacterial can be treated and cured, the viral can be treated, but they're never cured.
Sure. So let's talk about New York State and other states. When we look at kind of the top STIs that we think of, chlamydia, gonorrhea, can you talk about some of the top
Sure.
ranking, or maybe the most failing states?
I hate to
don't
say
know
the
best
top
way to
10,
put
but
it.
in looking at syphilis based on statistics from 2009, New York still rates in the top 10. We rate ninth highest of incidence of syphilis. When we look at the top 10 states of chlamydia, unfortunately, New York rates in the top 10 again. We rate 10th with the amount of incidence of chlamydia. Family planning clinics are beginning to address this, because almost every female who comes in for a family planning visit into the centers is being tested for chlamydia, so that's good. And of course, we know that human papillomavirus is also a very, very high STI. It's not necessarily right now on the charts that we're going to show you, but we know that the vaccines are beginning to roll out across the state, so hopefully we'll be able to make a dent in that. But we're sort of failing in syphilis and chlamydia, and we're also seeing some jumps in different populations looking at syphilis as well, especially looking at young men having sex with men. And we can talk about the special needs of LGBT population a little bit as we go on. Fortunately, in gonorrhea, hey, we didn't make the top 10, and that's something to be happy about. But I think that this slide reminds us that we need to pay attention to all sexual behavior, because sexually transmitted infections can be spread not just through penile-vaginal intercourse. They could be spread through cunnilingus. They can be spread through fellatio, both of which are oral sex, and they could be spread through penile-anal intercourse with semen and bodily fluid. So again, we're not just talking about traditional intercourse, even though that's what a lot of the statistics are looking at. This reminds us that we have to remember the sexual behavior of all of our young people and be able to address that.
Now, similar to what you are talking about in terms of the national trends, what we've seen in terms of trends in New York State look very similar. We met with Pat Curry-Doniger from the Center for Health and Behavioral Training in Rochester, New York, and she talked not only about the trends that they are seeing, but what her center has been doing about it. So let's take a look.
My name is Patricia Corey-Doniger. I'm a family nurse practitioner, and I'm the director for the Center for Health and Behavioral Training, which is a training center and a provision of technical assistance as well. I think the emphasis on evidence-based practice makes us different because it requires that you maintain, current knowledge of new interventions in the literature, and then have expertise in being able to translate research into practice and to implement, in the real world, these kind of interventions in a way that maintains their effectiveness but also makes them operational. One of the trends that's most disturbing is really the increase in new cases of HIV in youth. We saw this about late 2010 in Monroe County, where unfortunately in a period of about 9 months, about 50% of the cases, then newly reported cases of HIV were occurring in persons under 25. The definite risk for adolescents are primarily black MSM around HIV. But in terms of STDs, particularly also young females, females 15 to 19 have the highest burden of gonorrhea cases in Monroe County and elsewhere, and the next highest would be the 20 to 24, so almost half of all cases of gonorrhea are occurring in youth. Well, we've adapted in terms of meeting these trends by, for one thing, a community mobilization effort. So when we saw the trend where the new cases of HIV were occurring in youth, we looked further at the data, at the epidemiological data, and it was primarily in black MSM. But young black MSM, at least in Rochester, are often not out about their sexual orientation. And so to do something that was very specific with a focus on black gay men would not have necessarily met the target audience. So we made it more generic and focused on youth in the city of Rochester who are primarily black and Latino. So we had sort of subliminal messaging where some of the posters showed two males and not a male and female type of thing. And we produced a video, a hip hop song, which focused on totally showing young black MSM in different community settings and different activities. We have an approach in the clinic, which is a risk reduction strategy called stage-based behavioral counseling that's based on the person's readiness for change. And in particular, it's not patient education focused. So there's not what you perceive as lecturing to them about their sexuality, but it's really offering options for them that match their readiness. And so the secret is that they need to be talking more and you need to be talking less. And that's why we use that SBC approach. I also wanted to mention in terms of something very important for youth services would be for healthcare providers in whatever setting to be able to heavily promote the human papillomavirus vaccine. It's already been shown to have reduced the incidence of dysplasia and cervical cancer to some extent in young people and older people. So I think it's very important, even if youth can't get this because their parents don't consent, it can be given up to age 25 roughly. And so I think it'd be important for providers to heavily promote the vaccine when they see a teen, 18 or whatever, who doesn't need that parental consent. Because it's one of the most effective prevention strategies we have for dysplasia and cervical cancer, which disproportionately does affect a lot of young women, but also young men.
So the picture that you painted earlier is not necessarily a pretty picture, and some of the trends that Pat described are also pretty startling and not necessarily a pretty picture either. But it does seem like that center is doing some innovative work to try to reach the population. And I know you've got some experience with interventions or talking about what works. I mean, so we see we've got a problem. What do we do about it?
Well, Rachel, what I love about Pat's piece was the concept of let's bust the bubble. And I think that really is what we have to do. I think we have to make a paradigm shift. Audrey and I were talking about how many years experience we have working in the field and looking at being a peer educator and working with young people in different populations, whether they be in the city or whether they be rural. And we realized that there's not a cookie cutter approach. You would like to say this is the thing that works. This is what you have to do. But you have to meet people where they are. You have to be able to be culturally competent. You have to understand what young people are thinking and what their trends are and what their norms are of the day. And so there isn't really a silver bullet. There's not a sort of wish there was a magic wand that we could make it all go away, but there isn't. But there is one fascinating thing that I think if we're going to burst the bubble, we have to begin in our paradigm shift, and that's viewing young people as assets, not as problems. Young people have the ability, if given correct and honest and comprehensive, medically accurate, age-appropriate information, just like we would teach a young person to drive or to swim for the rest of their life skills that are going to help them. And based on where they are and their ability to suck up knowledge, if we can view young people as assets and begin to build on the assets they have and provide them that information and show them where they can go and get tested or get assistance and help them think a little differently about the relationships, maybe we might be able to take a chunk out of it. Government support is equally important, and I always say that it's a formula. You have to do education, and you have to provide the policy to ensure that young people have the access and the education, and then you have to provide the access to health services that they need. And if you add it together, there's just a wonderful, wonderful formula there that would help us bust the bubble in order to sort of make a little dent.
There's no single silver bullet approach, but are there other countries that have models or practices that you feel are more effective that maybe we could learn from?
Sure. For over 10 years, there's been this great field trip that unfortunately we probably have never been able to go to, but it's called the European Teen Sex Study Tour. And a group of politicians and interested people and sex educators and professors go to Europe, and they try to submerge themselves into what's going on to see why are the rates of STIs and teen pregnancy and HIV so low there? What are they doing? And some of the lessons that they've learned so far are very different than how we perceive sex and sexuality in our culture. For example, adults in developed countries see sexual relationships as normal and natural, and they acknowledge the fact that young people are going to be sexually curious.
Sure.
So if you know that that's the way young people are going to be, and I'm guessing that's the way that young people still are today, even in New York State and in the counties and our programs that we're working with, if we sort of thought about that paradigm, how would we change our message? How would we provide accurate and complete information and answer the questions, even though we may not be comfortable, maybe we may have to practice answering them, but we need to provide them. And how, again, do we support the role that educators and healthcare providers together make in being able to provide information and services at the same time?
Now, I know, Audrey, you're going to talk a lot about what the education component looks like and what are we doing in the schools, but I understand that in order to be effective, we really need to be looking at a bigger picture. It can't just be in the schools. So, Rob, talk to us a little bit about your experience. Who else should be getting involved, and how else can they get involved in promoting this safe sex message?
I say it takes a village. We sometimes say, let's wait for the talk. Let's wait for the family to get together and sit down. I'm sure, if you were going to look at the slide, we all sit down like that. And, there's a traditional mom and dad and the kids. And come on, let's all get out the, what's happening to my body books. And then we're going to have this conversation. Well, that's not real. What is real is that young people need to have an ongoing, open, honest, and consistent conversation. It's not just one talk. And it may not be with who you think it's going to be with. It may be with an aunt or a grandparent. It may be with an older brother or sister. It may be with a trusted family friend. It might be with a teacher. Whoever the young person has a discussion with, have the discussion and have many discussions. And however you play in your influence in the life of a young person, be open. Be askable. Be honest. And if you don't know the answer, turn to someone like Audrey or Planned Parenthood or the CDC or the New York State Department of Health website. Google a little bit and find out some ways to tell that. And be consistent. Don't just wait for the one sit-down conversation. These conversations, the teachable moments, can happen all the time.
Sure. And greater society plays a role in this too.
It does, and I think that if we're going to burst the bubble and we want to have a paradigm shift, I think that we have to sort of look at the way that we weigh morality of sexual behavior, and that we have to empower individuals to look at it ethically and to embrace 4 values. And I love these 4 values, and if we can just remember these: responsibility, respect, tolerance, and equity. And I just, I challenge everyone to think about this all the time. When we're doing our policy work or our program work or our education, or we're trying to just figure out how are we going to reach young people, are we doing it responsibly, are we doing it respectfully, are we doing it with tolerance, and are we doing it equitably?
And I think that's a great segue into talking about some of the populations that are maybe at greater risk for STIs. And one of the things you mentioned earlier was the LGBT population. I think that ties in really nicely with being respectful, promoting equity, et cetera. So can you talk a little bit about the situation and the greater risk for the LGBT population?
Sure. You know, Audrey and I both have experience working with LGBT youth, and we know that LGBT youth can be the same as every other young person walking down the street, except for the fact that there still is an element of discrimination and harassment that's occurring. And if you were going to look at the statistics, you would see, you know, the majority of young people who are perceived to be LGBT who are harassed at school. 4 out of 10 are physically harassed, 6 of 10 felt unsafe, 1 of 5 was physically assaulted at school. And you're probably wondering, you know, what's the relationship between harassment and bullying in school with STIs? Well, the first relationship is not only does it beat down on your self-esteem, but it makes you not want to go to school if you think about it, okay? So if you're receiving messages and being bullied and having violence towards you, you're going to miss days of school. You possibly are going to increase your substance use. You are worried that the class you're going to go into, someone's going to find out that you're gay. They're going to perceive that you're gay. You're going to zone out because the teacher is using exclusive heterocentric language. I don't necessarily use the word homophobic because I don't know if teachers are doing it on purpose. I think that it's just natural for some people to say, okay, we're going to talk about pregnancy prevention today, and then the gay or lesbian, bisexual kid, you know, zones out in the back going, well, it's not going to happen to me because that's not the type of sexual behavior I'm having.
Right.
Many safer sex examples don't include same-sex behaviors, and much sex education, even those that have been touted by the CDC, that we try to implement in our own programs, very often exclude same-sex relationships. So you have to then create scenarios and role plays and everything else. But we're not seeing in the classroom a value in those responsibility, respects, tolerance, and equity of sex education, including same-sex relationships as well.
Sure.
And I'm guessing that many teachers are not prepared, or maybe they're not competent, or maybe they're not comfortable to address same-sex relationship issues. And you know what I say? Okay, you get your pass. Acknowledge it, and then go do something about it.
Sure.
Because your class is full of the LGBT kids and the rest of the young people who may or may not be LGBT. And the whole class has to get along and learn from each other. We're in a state where everyone can get married now, so it's probably about time that we start talking about the 10% and the 90%, however you want to see the percent. But we have to acknowledge the fact that there are certain medical as well as psychosocial issues that play a part in trying to better meet our needs of our LGBTQ young people. And again, you know, to sort of sum it up, if you're not included, then you're going to continue to deny the risk. I remember an article that came out in a study probably a good 10 years ago that showed that lesbian and bisexual teens had higher teen pregnancy risks, because if you're looking at adolescence as the time that you're sexually experimenting with everybody. And again, you know, I guess the last thing I just like to say is we need to think about how we can make sex education and our prevention programs, those that have been approved and those that we're trying to replicate, to include same-sex examples and make them interesting, not only for those students we assume are heterosexual, but also those students that we assume are having homosexual or bisexual sexual behavior. And so the LGBTQ young person can feel a part of those conversations and can learn and thus reduce their risk as well.
Absolutely. So now you've shared quite a bit of information with us today. What would you say as your main takeaway message? You know, what's kind of the philosophy or the idea that you would want to promote based on your years of experience?
Audrey, would you agree with me?
Yes.
Trust young people. I think for so long we've always had this philosophy in our society that, you know, young people don't know what they're doing, and we can't trust them with information, and we have this negative connotation. We have to trust them. We have to believe that if given the right information, they're going to remember it and they're going to use it. We have to acknowledge that if we provide them a referral and show them where their family planning health center is, or their county clinic, or their nearest provider is, that they go there. And that we help them continue to sort of repeat the messages. They know in their head that, you know, having sex without protection is stupid and irresponsible. They'll tell you that. They know in their head, safer sex or no sex. sort of the disconnect is why that isn't occurring, and I think it's because we're not building a support system that trusts young people, that says, we trust you, we believe if given medically accurate, age-appropriate, comprehensive sex education, you're going to listen and learn. If given the information on where to go to get tested, you're going to get tested and understand why. And if given to be the opportunity to be a part of the solution instead of the problem, you'll want to be involved. And we see peer educators wanting to do this all the time. We see young people just coming to our information booths, asking questions, just eager to hear answers to questions that either they've been afraid to ask because our society's built up a sort of a cultural norm that you don't ask, or because they want to talk to someone who's askable. So let's trust young people.
Thank you, Rob. So one of the things that you're talking about there is, if given the age-appropriate, comprehensive information, that's how we can trust young people. And Audrey, that is your job, is to give that information. So why don't we start talking to you about some of the work that you do in New York State, and just sort of paint a picture of the information and the approaches that you're bringing into the classroom.
Yes, definitely, and thank you, Rob, for sharing all of that. As Rob said, New York State has extremely high rates of STDs, let alone teenage STDs among young people. They say about 1 in 2 sexually active young people will have an STD at some point in their life, which is very alarming. And a lot of the statistics I'll be pulling come from the Get Yourself Tested campaign, the GYT campaign. It's very popular and visible among young people, and I use it a lot in my programs. I work as a sexuality educator, so I go into schools, community groups. I work with all sorts of populations to teach about sexually transmitted infections and other topics relating to sex and sexuality.
So 1 in 2 young people,
Yes.
that's certainly that's a number that gets your attention. Now, if you break that number down by age category, what does that look like?
So about 25% of 15 to 19-year-olds will have an STD at some point in their lifetime. That's not saying how many of those people will know that they have an STD, because as we know, many infections may not show a symptom. I often tell people that they're lucky if they have a symptom, because then they know to go to the doctor. You know, if everything's okay, sometimes people won't think to go get tested. And among 20 to 24-year-olds, we say about 42% of them will have a sexually transmitted infection in their lifetime, which are very high rates.
Yeah, those are certainly numbers to be concerned about. Now, what if you break the information down by type of disease and who's at greater risk? Do you have information on that as well that you promote?
Definitely. So in New York State and across the country, a lot of the education that people do regarding sex and sexuality is HIV heavy. So a lot of people are pushing for HIV education for good reason. And they say about 1 in 5 people with HIV will not even know they have it, whether that's because they don't have symptoms. Symptoms take so long to show up for HIV, so many people who have this infection do not know it. More than 50%, which we talked about this a little bit earlier, more than 50% of young people will contract HPV at some time in their life, sexually active young people. And those rates are on the rise, even with the Gardasil vaccine. We're not sure if it's because of lack of access, just lack of education, but HPV is definitely something that we need to teach more about, because it can lead to cervical cancer. And chlamydia, as we said earlier, is the #1 most reported STD in New York State among young people. So there are many different infections. I find when I go into schools, most people know about HPV and herpes.
Okay.
I don't know if it's because that's what they've been taught about most, or just talking in the hallway, but those are the 2 infections that they know the most about.
Okay. And the information that they know, does it tend to be accurate, or is it just that they've heard those phrases before?
Sometimes. There's a lot of misinformation out there about sexuality, sex, what's safe, what's not safe. It's all up to someone's interpretation. But there's a lot of misinformation, and that's the role of educators, why we go into the classroom, to clear up those miscommunications, to teach them accurate information. A lot of the information they have on HIV is pretty up-to-date and accurate, but I find with the other infections, not so much.
Now, another thing where they might have misconceptions, seems like it should be an obvious question, but, you know, with in this new age of new experimentation, or maybe just things that we didn't talk about before, what are the ways that STIs or STDs are transmitted? I think, you know, and Rob talked earlier that we tend to focus on penile vaginal, but are there other ways, and what are the other ways that youth are at risk?
Yeah, when I talk about this, I usually break it down into what's the most risky. The 3 most riskiest behaviors are vaginal sex, oral sex, and anal sex. The one of those that's not often talked about is oral sex. A lot of times when I go into schools or even just chatter around the community when they talk about sex ed, people don't realize that you can get an infection from oral sex. Any of the infections that can be passed through vaginal sex or anal sex can be passed through oral sex. And that's something a lot of teens do not realize. So they're not taking precaution to keep themselves safe. There's also some less risky behaviors. Some infections can be passed through skin-to-skin contact, things like pubic lice, crabs, trichomoniasis. And then things like herpes can be passed through kissing. So those are less risky behaviors, but we talk about them because they still pose a risk.
Sure. Now, so one of the ways that we can try to address this situation, that there's a number of different ways that a number of different diseases can be transmitted from one person to another, is through education.
Yes.
So talk to us about what comprehensive sex education, what does that mean?
So there are a couple different sex education models out there. The one I follow at Planned Parenthood as an educator is comprehensive sex ed. And that is age-appropriate information. So starting the discussion from a young age, but meeting those people where they're at. You know, the question a 5-year-old asks is not going to be the same question as a 15-year-old asks.
Sure.
But they're going to have questions. And you answer that in a way that's appropriate for their age, not giving them too much information, but not leaving them wondering. So comprehensive sex education is age appropriate. It's medically accurate. We use statistics. We get a lot of our statistics from the Center for Disease Control. So we're using stuff that's statistically, scientifically, medically accurate. And we're meeting people where they're at. We're not passing judgment. A big part of comprehensive sex ed is teaching to particular groups and looking at the things that they're encountering. So not going into a group of students or adults even and passing judgment or assuming that they know something or don't know something, but tailoring your education to the communities in which you're presenting to.
Sure. And so given that model that you just described, what are some of the results that you've seen or that you see as a result when someone receives comprehensive sex education?
So there have been a few different studies on comprehensive sex ed and its effectiveness. Those studies have said that 40% of people who have comprehensive sex education in their schools delay sexual initiation. So the age at which they first have sex is later. It reduces the number of sexual partners, whether that be monogamy or just fewer partners. And it increases condom and contraceptive use. So it increases the rate at which they're using those methods to keep themselves safer. 30% and 30% of people, it reduced the frequency of sex, so how often they're having sex. And for a lot of people, about 30%, it included a return to abstinence. So what I mean is people who have had sexual encounters with individuals and then decided that that wasn't right for them, that they did in fact want to be abstinent. In 60%, so over half of those students who had comprehensive sex education, it reduced the amount of unprotected sex.
Well, those are really, given that we've been kind of, I don't want to say painting a doom and gloom picture, but what we've been looking at are some pretty dark statistics about the trends we're seeing. Those statistics actually kind of provide us a little bit of hope, right? That if given the right tools, we can change the direction that this is going.
Definitely.
Now, one of the things you mentioned earlier that there's several approaches to sex education, and you follow the comprehensive sex education. Can you talk to us about, there's the debate. I mean, everyone knows there's politics, and some folks favor the abstinence only. And can you talk to us about why you follow a comprehensive model as opposed to abstinence only?
Yes, we see comprehensive sex education as all-inclusive. So we're talking and even focusing a great deal of our education on abstinence and telling people why that can work, that it's the only method that's 100% effective if used properly at preventing infections in pregnancy. What makes it different than the abstinence only is that it's giving people information whether they need it or not, and that makes some people uncomfortable. We realize when we go into a classroom that not all students are sexually active, but we also realize and acknowledge that some students are. And that's an important thing to realize, even though it might make some people or parents uncomfortable. We're giving them the information. I always say if they needed it yesterday and it's too late, if they need it right now, it's pertinent to their lives, or if they need it 5 years from now, it's better to have the information and not need it than to need it and not have it.
Sure.
Audrey, that was so well said.
I know, I've practiced this.
That's great. and I think it perfectly jives with some of the scary statistics, because when we think about abstinence, we think about, well, of course, we know that abstinence is the best way to prevent STIs and unwanted pregnancy. Some of the challenges we have, if you were going to ask a young person what abstinence means, Is their answer, well, it only means I'm not having penile-vaginal intercourse, and all of a sudden, you see the stats are all skewed. But I think what's fascinating about your explanation about the abstinence-only programs is there's always been this strange, misunderstanding that comprehensive sex education doesn't include abstinence, and it's like, well, that's sort of the basic foundation when you're going to look, when you look.
That's where we start from, right?
You look at your riskiest and you look at, okay, what does a good program need? What messages do you have to say? And you say, well, if you don't want to have any risk of contracting, giving or getting an STD, STI, or getting someone pregnant or getting pregnant, this is what you need.
Right.
And then you build your risk up
there.
from there. I think that's fascinating. It's well said.
And one of the most important parts when we do teach about abstinence is letting students know that there's no specific definition of it. You can't look in a dictionary and it won't tell you what behaviors to avoid. So it's telling students that they have the option to create that definition for themselves and teaching self-empowerment so that they feel comfortable, acting it out or not acting it out. If they have the information and aren't comfortable using it, it's not going to make a difference.
Sure. So talk to us about specifically what does sex education look like in our schools?
Sure. So it varies between schools. Planned Parenthood, whether it be Mohawk Hudson or Upper Hudson here in Albany, are in a lot of different school districts. We're invited to come in for teachers, community groups, one-on-ones with students, and that's practicing comprehensive sex ed. We tailor it to the classroom and what the teacher wants. There are some schools who still focus heavily on abstinence, who have abstinence-only curriculums, and there are also schools who kind of keep it just HIV, which is something I think we'll talk about a little bit later. In New York State, the standard is only HIV education. There's no law saying that you have to talk about contraception or that you have to talk about the prevention of all of these infections. It's very HIV heavy. So it really depends on what school.
And what are the New York State, the state sex ed guidelines?
The guidelines are very HIV focused, as I said. The only rule that New York State puts out is that you teach about HIV and prevention, which is leaving out a whole range of topics that students need to learn about that are affecting them. But with the national sex ed guidelines, which are always being updated, it's more comprehensive focused and teaching about contraceptions and different infections and healthy relationships and everything that goes along with that.
So one of the things I think that makes this such a hot topic or potentially controversial topic is because we're talking about science and scientifically accurate information, but we're also talking about youth. And so youth have parents who have an invested stake in what happens with their children. So do we know anything about what parents want? What do they want their children to be hearing?
Definitely, and we've looked at that a lot, and part of our education program is encouraging that discussion between parents or guardians or even just a trusted adult. We really encourage students to have that conversation as they can. But we found that most parents actually want comprehensive sex education, whether it be because they don't feel like they can answer the questions or they're not comfortable answering the questions. Most parents want that to happen in their school. They want a broad sex education curriculum covering a number of topics, including how babies are made, so reproduction. I think that's a key one to teach about. How to put on a condom, how to get tested for STIs, how to access reproductive health care services. And also, over 99% wanted information on STIs other than HIV. So parents realize that HIV isn't the only infection out there. Also, most parents wanted their students to know how to get tested for these infections, not just focused on pregnancy prevention.
So parents are really looking for a comprehensive approach then. Do you have other information about specific things that parents want their children to know about?
Sure. About 93% of the parents that have been surveyed wanted information about waiting until marriage. So waiting to have sex until marriage. And I think marriage is a loaded term that could mean a lot of different things for a lot of different people. And depending on where you're looking in the United States, marriage might not be inclusive to everyone, as we know. So they said waiting until marriage, but we recognize that that might not be mean the same for everybody. 83% wanted their students or young people, children, to know how to put on a condom, whether that be for pregnancy prevention or prevention of infections. And 71% wanted their kids to know how to obtain birth control pills from family planning clinics.
So that's, really the kind of the sense that you get from that data is that parents are trusting their children, or they do want their children to be informed. An informed youth is an empowered youth to make responsible decisions. So, as an educator, what are some of the things that you're seeing? Talk to us about your perspective from the work that you're doing.
A lot of times when I go into the classroom, people have preconceived notions about what I'm going to teach about because that's all they've ever had, that's all they've ever known. There are many students who don't have a trusted adult in their life that will give them factual information or who will not shame their questions. So when I go in, I always make it a safe space to ask questions. No question is off limits. Creating an area where there's no judgment passed on behaviors or what kids are inquiring about. Trends I've seen in the classroom, a lot of students think it's going to be abstinence only. So they don't think I'm going to teach about the other things. But there's a lot of questions out there. There's a lot of things that people have heard on the school bus, in the hallways, and they want answers to it. Whether it be about the effectiveness of birth control or how you can pass infections. There's a lot of misconceptions, as we said, about how infections can be passed. And that's one of the most frequent questions I get in the classroom.
Interesting.
Yeah.
And now you mentioned earlier, and Rob mentioned earlier, special considerations and making sure that we're being culturally competent for LGBT youth. So how do you incorporate that in the classroom?
I try to normalize it the best I can because it is a normal part of people's lives. And there are going to be LGBT students in the classroom, whether we want to acknowledge it or not. So it's an important part of everything I do, making everything inclusive of LGBT students. So when I go into a classroom, if I'm talking about pregnancy prevention, I try to give a disclaimer and say, you know, this may not be pertinent to your sexual behavior, may not be pertinent to your life, but you may have a friend who needs the information. You can always help someone else out. Including LGBT statistics or pictures, simple things like that to make them realize that we're not forgetting about them, that they're not invisible, making them an active part of the conversation, and also letting people know that these STDs don't discriminate. Anyone, regardless of who they're partnering with and what that person's gender is, can get an infection, which is something that many youth don't realize.
And so is that one of the core messages or the core pieces of information that you try to get across?
Yes, always. Whether it be in a healthy relationships program, a program on gender and stereotypes, or something on infections, I try to make everything I do LGBT inclusive.
I think that's great because that goes back to one of those 4 major values about equity. And, you know, being able to ask in a classroom when someone asks a question, well, if you're having sex with your girlfriend or your boyfriend or both, and all of a sudden you've just opened the door to all possibilities, and then ears start perking up.
And it makes a safer space to ask questions. You know, if you're not acknowledging someone's life or their being or
they're
their
not going to ask the questions, they're not going to get the information, and the problem is going to continue.
They're going to feel excluded,
So we have quite a few questions from our audience. So let's kind of just kind of wrap up with sort of what the prevention efforts are that you're doing to try to mitigate and you know, the work that you're doing in your classroom, and then we'll hear from the audience a little bit.
Definitely. So like I said before, it's just meeting people where they are at, not where they at. It's going into a community and, you know, examining your surroundings before you teach to them. Asking the teacher about their students, because when I go into a classroom, the teacher is the one who knows their students, not me.
Right.
Creating a safe space to ask questions, giving them medically accurate information that meets them at what age they're at.
It sounds like you're doing great work, and thank you so much for sharing the work that you're doing with us today, because I think those are some of the questions that folks have, or how can we address this issue? So I'm going to start, let's see, we've got, how does viral hepatitis fit in with HIV and STIs within the discussion we've had today?
So we do talk about hepatitis as one of the infections that can be passed, and we know there's different types of hepatitis, and it can be passed various ways. But that is an infection that we get a lot of questions about. We teach that it's a viral infection. You can treat the symptoms. You can't get rid of it. If you have a virus, it's always going to be there.
Okay, thank you. Rob, can you talk more about how do lesbian teens have a higher pregnancy risk, and what data is collected to determine the number of people 13 and under who are infected with HIV?
Okay.
So 2 separate questions.
Well, you know, the first question, you know, the statistics come from reputable sources. You could check them out yourself on cdc.gov. So, and it breaks down in cohorts by age what's happening. You can also look for STIs in our own state by the STI surveillance report that's put out by the Department of Health. I'm sure if you go to the Department of Health website, you can sort of download that too. So the information based on the age cohort is broken down by metrics, looking at 13 and under, and then looking through the adolescent years. Then you look at the 20 years, and they have certain parameters of how they're all how it's all being gathered. Okay, so I encourage folks to go to cdc.gov or go to your county Department of Health website, Vital Statistics. It'll show you, and it's all broken down by age, and it's all broken down by everything from you could get cultural backgrounds as well as gender.
Yeah, there's lots of information
There's-
out there.
there's
I've
lots
looked
there,
myself.
believe me,
So
you know. But the first question I think is more interesting, and I'm going to ask you to repeat it again.
can you talk more about lesbians having a higher teen pregnancy rate?
The interesting article that came out was looking at a cohort of young women who were having sex with men as well, or young men, teen males as well as females. And I suppose you could define them as bisexual, but when you're looking at adolescents, it's very common to realize that sexuality is fluid, and that during adolescence, experimentation happens. And very often, if somebody thinks that they are labeled a certain orientation, that could work against their ability to practice safer sex. For example, if I thought I was a lesbian and then I ended up hooking up with a guy who I liked, I'm going to think, well, I probably don't have to worry about getting pregnant because I'm a lesbian, right? Except that
Or you've never listened to the messages.
or I never
before
listened to the
because you
messages in
thought
the
you were
first part,
explicit.
except the sexual behavior is the sexual behavior.
Right.
You know, so you have your labels,
Right.
and you have your special populations you want to pay attention to, but sexual behavior is still going to be sexual behavior.
Sure.
And in this particular study, and I wish I could quote it right now, and I'd be more than happy to follow up, I found it interesting because we forget that during adolescence, if you're raised in a heterocentric society, you're going to think that you're supposed to hook up with someone of the opposite sex, but your body is telling you want to hook up with someone of the same sex, so you may be doing both,
Right.
which may put you at risk for unwanted pregnancy
Sure.
and will put you at risk for STIs based on whether you're having sex with men, women, or both.
Yeah, I think the main thing to realize, and that's a question we get a lot, this study shocked a lot of people, but it's separating identity from behavior.
Right.
Yeah.
Someone can identify as a lesbian and still have sex with men.
And that kind of
Yeah.
goes to what Pat spoke about on that pre-taped clip that we showed, where men having sex with men who don't identify as gay. So I think that's a really good point.
And then I'll blow your mind and say you fall in love with the person.
Right.
And this in the situation and whatever
Sure.
else is going on and what society says and what your family says you should be doing. And all of a sudden you see it's not as simple as a sexual act.
Orientation.
Yeah.
So can either of you explain for our audience briefly the difference between STI and STD?
That is a question I
I'm
get.
glad we got that question.
That's a question we get in every class. We use the terms interchangeably. There have been a lot of different terms to describe sexually transmitted infections throughout time. It started out as venereal diseases and then sexually transmitted diseases, and now people are using sexually transmitted infections. Two terms used interchangeably mean the same thing. Some people feel more comfortable using one or the other. I think the reason they moved more toward using STI is because not all of these may be seen as a disease. It might give the wrong connotation.
So it doesn't necessarily mean that one means bacterial or one means viral. It just sort
Just
of
a language.
language,
Right.
exactly.
All right, we have just a few more minutes before the show ends. I'm going to try to get some more questions in. Can you talk about the importance of language that providers use when talking to teens about sexual behaviors and as it relates to them being better able to understand the acts that they're engaging in?
Sure. It's using language that's not judgmental. I think that's the most important thing. Not assuming you know the person, because you may not, or not using adultist language that could place yourself at a higher level. You want to talk to the student as if you're their equal or the teenager. And not assuming anything about their behaviors either. You may think you can tell someone's orientation or behaviors by looking at them, but you can't. So it's meeting someone where they're at and not passing assumptions.
And I often think it's great to clarify so that if someone says hooking up, I say to them, now when you say hooking up, is that going out on a date or is that having anonymous sex? Let's just make sure we're on the same page. And I would also just put another plug in for being inclusive. Because,
Absolutely.
if you're a gay, lesbian, bisexual, or even transgender person sitting in the back of the room and you think none of this has anything to do with you and you hear your teacher just say, if you have sex with men or women or both, whether you're a boy having sex with a boy or a girl having sex with a girl, all of a sudden you start feeling more comfortable about yourself and better about yourself, and you want to tune in and you want to pay attention. And all of a sudden, that person's paradigm shifts and they go, wow, this is something that I have to pay attention to.
Absolutely.
And you are askable. Oh, and you are a really cool teacher after all. You know?
And all the good things that come with that, engaging
there
students.
goes your self-esteem, and all of a sudden, you know.
It increases your rapport among the students too. It makes them
Certainly.
trust you more.
Well, thank you guys both. We still have more questions, but we are unfortunately out of time, so hopefully we'll be able to answer some of these and respond directly to people off the air. But thank you both so much for all the information you've shared with us today.
It's been a pleasure.
And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming broadcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help further your knowledge and understanding of topics covered in today's program. This webcast will be available on our website on demand within 2 weeks, and DVDs of any of our Public Health Live broadcasts can be ordered from our website as well. Please join us for our next broadcast on September 19th, where we'll be discussing about the hidden dangers of radon. I'm Rachel Breitster. Thanks so much for joining us today on Public Health Live.